everybody. My name is Jennifer Olmsted, and I am the Senior Director of Governance and Operations here at the San Diego County Medical Society. In partnership with the Doctors Company, I would like to welcome you to our first webinar of 2025 entitled The Top 5 Risks for Your Practice. We have two terrific presenters for you this evening. We have Kathleen Stillwell, who is the Senior Patient Safety Risk Manager with the Doctors Company. And we also have Kathy Nichols, who is an Associate Attorney with Carlson and Jayakumar. And now I'd like to introduce Kathleen Stillwell. Kathleen?
Good evening. Thank you, Jen, and also to Paul, who's not with us tonight. We appreciate the partnership with San Diego County Medical Society, and we hope that tonight's program will bring you some new information and help you deal with understanding the risks in your practice, but also identify strategies to help reduce them. I am the Senior Patient Safety Risk Manager with the Doctors Company. I know we have a number of Doctors Company members with us, as well as San Diego Medical Society members, and we really appreciate you at the end of a really busy day taking time to join this session. I'm especially grateful to Kathy Nichols. She is an Associate Attorney at Carlson and Jayakumar, with a firm that is also an endorsed business partner with San Diego County Medical Society, with OCMA, and with Los Angeles County. And I love to partner with this firm because they have the very best attorneys, and you're going to be really happy to hear her messages tonight. Our objectives are to look at risks, to help you understand how to assess your own practice, and then learn strategies to help you overcome the risks. I like to always start with some inspiration, and for this program, I found my inspiration with Gandhi. He said, "Strength comes not from winning. Your struggles develop your strengths. When you go through hardships and decide not to surrender, that is strength." Nobody has gone through more hardships and had to struggle than the healthcare industry, especially since the pandemic. And just when we think it's getting better, something changes that throws us off course, whether it's something from the Fed, something from the state, something from reimbursement, staffing issues. So congratulations to all of you, you're survivors. Malpractice is not your biggest risk. In fact, it's not even in the top 5. You do such a great job. Physicians, yes, they get sued, but just at the Doctors Company alone, we have 100,000 members nationwide. Our statistic is 86% of our doctors who get sued for a malpractice claim, 86% consistently every year. It's 86 to 88% actually, and they are dismissed with nothing paid to the patient. That shows you an example of how rampant the malpractice cases are, but they're nothing cases. And this slide just talks about why patients sue. And I'm not going to go through details on every slide. You will have a copy of the slides available to you. The citations for anything with data and information is included on the slide. You can just click and go to that site. But most of all, I want to tell you that we see that patients sue most of all because of the last 2 bullets: unrealistic expectations and anger. And sometimes it's not the patient, it's a family member or someone in their circle of life who goads them into saying, you know, this shouldn't have happened. You need to sue. And what we find actually, and you'll see tonight and you'll hear this, they don't sue, they take revenge and retaliation with other strategies. Now let's talk about the top 5, and I'm going to go quickly. Again, I'm not going to read every slide. I'm going to highlight cyber attack is your number 1 risk. And I want to say not just in your practice, but in your own personal computer and on your cell phone. And you're going to hear from me tonight about how the culprits out there are cyber attacking us on our cell phones. 2024 was a bad year for healthcare ransomware attacks. This slide shows you that there was over 1,200 confirmed attacks in 2024. And look at how many records were compromised: 195 million. And look at the average ransom demand was over $3.5 million. And healthcare paid $133.5 million in confirmed payments. But what really bothered me was when I saw the average ransom payment was $9 million plus. Why did that shock me? Because if you look at the average ransom payment in 2023, it was less than $6 million. That's how much it jumped in 1 year. It was a bad year. I want to talk about phishing intelligence report. Look at this. In 2024, phishing surged 703%. I've never even seen any statistic on anything that was a 700%. And over 90% of successful cyber attacks start with a phishing email. That's where you get in different types of email, and I'm going to tell you about them. An email phishing is it appears to be from a legitimate business asking you to update or verify your personal information. You're going to get these on your own computer. You're going to get them on your cell phone. And just remember, probably in your practice, you might have some protection. Maybe with your homeowner's insurance, you have some protection. I can tell you if you're with the doctor's company, we have under our CyberGuard coverage, you have $50,000 worth of protection, which is for remediation, investigation, and ransom. You have that, but that's not very much when you look at what it takes to recover data. Spear phishing is cyber criminals send an email to a person that includes something personal to trick you. And I had one yesterday on my phone, and it said, you used your PayPal account for a purchase, and we could not close the sale due to missing information. Please enter your password and your name and your password. Well, I don't even have a PayPal account. I used to, but I dropped all those things several years ago. And you'll get things at work. And please, I hope in your practice, you forbid your staff to use your office computer for anything surfing the internet on their break, on their lunch, because this is where most of the attacks happen. It comes in when people are using the internet on your computer. How about smishing and vishing? Scammers send smishing is when they send you a text message, and we've been getting those a lot for about the last 8 months. And also they call you on the phone and they ask for something, and delete it, just say I'm not interested, hang up, and then block the number. Angler phishing is a new one, and that's where they target social media with people disguised as a customer service agent. So they might come to your social media site on your website, or if you have a place where you're listed, RateMD, Angie's List, Yelp, and if you have something posted, and they'll come and say, I'm a customer service agent with social media and wanted to confirm your address or something, and they just never answer anything. Don't answer anybody, and you'll hear more about social media tonight. But this is the biggest fight you have, is phishing, and that mostly is going to include your staff. Implement multi-factor authentication. We had to do that 3 years ago at the doctor's company. I mean, I have to put in 3 passwords and a fingerprint to get into my phone and to get into my system. And it's the simplest security control to implement. Your IT people can tell you how to do it. The banks use it. Everyone's going to that now. You can use facial recognition or a fingerprint. And IT experts estimate that up to 90% of cyber attacks could be prevented if you used multi-factor authentication on your computers and your mobile devices. So this is your iPads as well. It's a minimum security process. So here are the recommendations. Assume you're going to be hit. Plan with your IT people. Make backups of your data. If your data gets taken ransom, and I get a fair number of calls, it's decreased now because people have gotten very proficient at protecting their documents and their data. But it goes like this. They come in and they lock up your computer. They might go into your business systems, your scheduling system, your electronic health record system, or all of the systems, and any one of them, and they'll say, then they send you a note or a letter, or they call you and say, well, if you want it, you have to pay us $1 million to get it back. Well, don't even talk to them. You need to call your malpractice carrier, because most of the carriers provide the guidance on where to go next. At the doctor's company, we refer you to this third-party service we use that helps you. And just to make you feel a little bit better, I will tell you that in the solo practice and small groups that have had ransomware, We've seen great success with them getting their data back, but they don't retrieve the data because the experts would need anywhere from 6 to 16 weeks or longer to recover data. And how are you going to run your business if you can't get into your scheduling, can't get into your billing, if you can't get into your EHR or any one of those? And so then the third party that we use negotiates the ransom. And you might be thinking, $1 million, what am I going to do? And I only have a $50,000 policy with the doctor's company, although many buy up to $1 million. And here's what I want to tell you. Most recent one I had, they negotiated it down to $250,000. And then the doctor said, no, I don't have it. And they got it down, and it ended up the doctor got his data back for $8,000. So some of these people aren't that sophisticated. They're going to take what they can get. They also install malware on your computer, which puts you at risk for other people to get into your system. And some scammers are just trying to get in to plant something in your system. I think I've already talked about this, but you do have to have a firewall to prevent the cyber attack. This is the list of things to do. You have to have strong passwords, change them frequently. I want to say something about protecting mobile devices. And in addition to cyber, you want to have to understand that if you have used your personal cell phone, or if you have any of your staff in the office using their personal cell phone, if you're involved in litigation, I'm going to tell you that now plaintiff and defense attorneys ask for the metadata, that's the electronic footprint on your phones, to go see. And if you're texting or emailing or having conversations with patients and it's not encrypted, that's number one, that's a HIPAA violation. Number two, if you're using your private phone and you have other things on your phone you wouldn't want people to see, private messages, photographs, things that aren't for the consumption of the general public, I want you to know that they're going to get it. And you can try and fight it. We've had attorneys say, we're going to fight it. You can't get this, you can't get that. But the bottom line is, yes, maybe they get it in camera review, but they're going to come after your metadata on your cell phone. So the recommendation from the doctor's company is, number one, you don't let your staff use their private phones. Get a burner phone for the office. And for yourself, don't use your personal cell phone. You can get just a phone for a flip phone. Don't text with people. Anything you text, you have to print and scan into the medical record, and that's time intensive. Documentation is your silent witness, and I want to show you some actual things I extracted from medical record reviews I've done, and I'm not going to review them all, of course, but these are things that I found that doctors or the staff actually said. And the reason they're on this slide is because in every one of these instances with open notes that became apparent in 2022, patients are looking over your shoulder and they have the right to have full access to everything in the EHR. And in each one of these cases, they filed a medical board complaint with the medical board. And it's been a couple of years and not one of these has completely been adjudicated. Your documentation is your best defense. It's at the time you were seeing the patient. It's going to be viewed by a lot of people. The most important one I want you to see there is the patient and the family, because now they see everything, including administrative notes, July 1, 2024. All of your administrative notes in the EHR are open. So you and your staff should be documenting as though the patient is looking over your shoulder. The biggest problem we see is, of course, errors in treatment, delays, misinterpretation of care if you don't have good documentation. You also have no defense documentation for the medical board or grievances and in a malpractice case. And don't forget, your billing reimbursement is based on the documentation as well. If it's not documented, it wasn't done. I'm going to just let that sit there because you heard that in medical school. And while we know that's not true, you can't document everything. I want to move on in the interest of time. I talked about metadata. Just remember, it's forever. It's like herpes. You can't get over it. You can't get rid of it. You have to have it forever. Amending the medical record depends on what your medical records policy is. If you have a small group, you might not even have a written policy. Just be aware a late entry is different than something you add a month or two later. If you have an EHR, it's immaterial because it will date stamp the time of the entry. Copy and paste has its own pitfalls, so you want to be careful about doing that. And you can reference and say, evaluation from February 1, 2025, evaluation posted, no changes noted. And you could copy and paste it if you said you did that. These are things that I think pretty much speak for themselves, but I want to remind you about finger pointing. We don't want to finger point at anybody, at staff. You don't want your staff finger pointing at anybody. And we definitely want to be careful about editorial comments about patients. And I see that actually more with the staff sometimes. Documenting difficult issues. I think the thing that is most important to say is the third bullet. Use quotes around the words the patient said. It's useless to document patient was rude and used foul language. That will mean nothing to the medical board. But if you say patient asked for blank, was advised, physician not available, patient raised his voice and said, in quotation marks, what they said with the words, that's what's going to be important. We don't want to hear unsubstantiated statements, obviously, and hearsay, and never reference to legal action or incident reports. And you also don't want to say, I spoke with my attorney about in the record, in the patient record, and you're not going to say, I called my malpractice carrier, I spoke to Kathleen at TDC. You would never put that in the patient's medical record. This is my last slide. I'm going to turn it over to Kathy. And just to remind you, one of the most important things that I want you to think about is the differential diagnosis and patient education. If you have a differential diagnosis, you don't have it yet, it could be consider differential diagnosis once labs or imaging studies are available. That shows you we're thinking about something. And why do we want to do that? Because 87% of doctors' company closed claims we see are related to diagnostic error. That means no diagnosis, wrong diagnosis, late diagnosis, or a failure to refer to someone to get the right diagnosis. With that, I'm going to turn it over to Kathy, and she is going to enlighten us on regulatory compliance. Kathy?
Sure. Thank you, Kathleen. Yes, regulatory compliance, HIPAA, as you all know, that the acronym of the Health Insurance Portability Act. And this kind of goes hand in hand with all the cybersecurity attack slides that Kathleen went over. And one of the reasons why is that medical information is 10 times more valuable than like credit card information, which used to be sort of the top thing that criminals would go after. But now it's medical information, which has just a treasure trove of things all in one place, sometimes all on the first page of a record, the intake sheet or something like that. So we really need to make sure this is maintained in a secure place. And then HIPAA is a federal law. There's also state privacy laws that apply to records as well. But HIPAA is the one that's kind of over all of that. And so we'll go over kind of the most common violations here in terms of risk for your practice. Faxing to the wrong number is actually one that I've had that happen for a client before, where it wasn't actually faxing, but it was on the phone disclosing a record, medical information to a patient. The name was literally almost the same and they disclosed the wrong information, which is an innocent mistake. It still required a little bit of analysis to figure out if it was something that needed to be reported or not. And so you just want to kind of think about these things in the back of your mind. And really, a lot of these bullet points come back to making sure that your staff is aware of what these privacy obligations are. Texting and emailing patients without encrypted systems. Kathleen kind of touched on this, where you have either a provider or a staff or a support staff person texting with patients, just kind of information about when the appointment is or things like that. It just quickly can escalate in terms of getting into PHI, which is private health information. So you want to just find, there's many out there, but find a HIPAA secure texting platform, email platform. There's a lot out there, and have all communications go through those platforms. And that is going to be your best bet to kind of mitigate your risk. And then the other one there is, let's see, inappropriate release of medical information. Again, you need to make sure that you've got the consent on where the records are supposed to be released. There are certain exceptions, obviously releasing information to payers like Medicare and insurance companies don't require authorization, but sending information to an attorney or any kind of investigative subpoena, if you don't have the patient's consent, you need to sort of think twice about it. And then that last one there, the no social media policy, I think there's a little bit more information that Kathleen's going to touch on this further in terms of like engaging with patients on social media, which is really kind of increases the risk of kind of a disclosure of PHI. So next slide. Some additional common HIPAA violations. The first one there, failure to perform a risk analysis. So the recommendation is to do an annual risk analysis, which just means kind of going through and making sure, like, do we have a HIPAA compliant EHR system? Are all the staff who have been onboarded for the past year, have they done their HIPAA training? It's just sort of a checklist you can go through, and there's a lot online that kind of can help guide you on what you need to look at. There isn't anything like legally required, but it is definitely something that can help you mitigate your risk. And sort of the same thing, failure to promptly release information to patients. Kathleen kind of touched on this. This is always a hot button issue with patients requesting records, and a lot of times the provider isn't even aware. It's going through the staff, and the staff have sort of dropped the ball, so to speak, and the provider is the one that's on the hook. So you need to have those processes in place so that if patients have requested that information, they're getting it in a timely manner. Otherwise, it can result in, not only a medical board complaint, but potentially fines for not providing that information under both federal and state law. Unauthorized access to medical records, insider snooping, that a lot of times is right within your organization, is where you have a staff member accessing records that isn't a permissible reason under HIPAA, so basically not related to treatment. They're sort of looky-loos. And you see it from time to time, and that does increase risk. So again, going back to the HIPAA training and making sure employees understand what's required. Missing patient signatures, again, kind of going back to making sure you have the authorizations so patients are aware of where their information is going without their authorization. So that's simply your notice of privacy practices, and then making sure you have those authorizations on, for example, if they're going to be releasing information through some kind of email platform or something like that, and having those releases in place. Next one. So kind of the most frequent HIPAA complaints that we see are the impermissible, probably the one on here I'll just touch on quickly is the lack of patient access to their PHI. That's probably the biggest one that we see. And that one, again, a lot of times it isn't something that's intentional. It's a busy practice, and the staff is not attending to a patient's request for records. The patient maybe isn't going about the most efficient way to request the records, but of course, once they make the request, especially if it's in writing, the clock is ticking to make sure that that is provided to them within the statutory period of time. The other ones that I can touch on the top one there, impermissible use and disclosure of PHI. Where I've seen this is where providers have photographs, medical appropriately photographs, either on their own laptops or their own devices, basically. I had a plastic surgeon who had all of her photos on her own personal laptop. They were completely outside of the institution's EHR platform. And so when the time came for we needed those images for a regulatory matter, so legally required to turn this stuff over, we had no way of finding it. So it was hard to track it down, and then a little bit horrifying to find out that it was just like sitting on her laptop, all these kind of before and after photos. So again, that was a plastic surgeon at a top institution was doing that. You can imagine that kind of sets out kind of what can happen if we don't kind of have the training in place and the awareness of how this information needs to be maintained. lacking safeguards for protected information. So this again goes back to having, encrypted emails. I think Kathleen touched on this, and having those things in place up front. So the expectation for the patient is it's an encrypted texting and or emailing or both platform that they are communicating with the practice. That's the easiest way to sort of limit your risk, as opposed to just kind of leaving it up to like however the patient reaches out. And the last thing there is the use and disclosure of more than the minimum necessary PHI. So this is just, it's kind of says it right there, but basically only releasing what's necessary. When you submit a claim for payment, you're submitting just like the basics to get paid, right? You're not submitting the entire record. So that's kind of a silly example, but that's kind of where that comes from, is like when there's a request for example, another provider says, send me the records for X, like you're just sending that. You're not sending anything beyond that. And where we get into trouble is if there's any substance abuse records, any psychiatric records within the patient's file. If the request is limited and that information is released, you're looking at some major HIPAA breaches there. So you want to be aware of what's requested and only provide that. So these are the violations. I would say it's a big range there. And the reason for that is the culpability of the violations range. You can see there's criminal penalties. So there's 4 tiers, basically. It's from unintentional, so just kind of the ones I mentioned where, the staff just didn't get trained in time. No one meant any harm, but someone just dropped the ball. That is, sort of tier 1. Tier 2 is negligence, where they should have known better. So, that you should have, an EHR system that is encrypted, and you don't. You just kind of use a fly-by-night, tech company and everything is just exposed. That would be more on the tier 2. Tier 3 is a willful negligence. So through your sort of willful neglect, like you really should have known better. And there were all the warning signs and you still didn't. But if you timely correct that, that's sort of tier 3. And then tier 4 is the one where you really see those really hefty fines, is just a willful neglect. And then you don't take timely corrective actions. So you just kind of, don't take any action, and that's where you can see kind of those increased fines. And again, I think this is on the next slide, maybe. So this one shows the impacted individual and how much that fluctuate, where that top one, or actually, yeah, the bottom one is like a 10,000, and then it goes on up to that third one, which is 160. So, that could be, multiples of complaints that provider had. So these statistics come from, these are actual statistics. So that's what that could be indicative of, as well as that range is, it's a per record violation. So that's why, you may have seen in the news when like Anthem has a big breach. First off, if it's over the 500, you've got to like notify by media. So that can get very expensive very quickly. And then you've got kind of these notice of breach processes and several other layers of regulations to sort of go through if it is a large breach. Plus, again, going through those tiers, if it's something that really you should have known better and you didn't have kind of the basics in place, that's where we can sort of see those really hefty fines. But I would say for the most part in my practice, it's definitely tier 1, and it's more the headaches are in the reporting, hiring a lawyer to sort of look at everything and find out what the risk is and what you need to do, and you have to tell the patient. So it is still, the really large ones are still mostly with large organizations. There was like a famous one where they just like dumped a bunch of records in the trash in a big dumpster. See, we're seeing less and less of that. More of it is what Kathleen was talking about, where you have like a cybersecurity attack. And so if you haven't put those protections in place, then you're looking more at like tier 2 or tier 3, like you really should have had that in place. So the HIPAA checklist. So like I said before, the annual security assessment, this isn't a requirement. You don't have to like provide proof of it. Again, the way to mitigate your risk would be to do it and document and say, okay, we do our risk assessment every January or something like that, where you're just kind of going through a checklist of, you have encryption, you have all the technical requirements in place for HIPAA. I would say the third one there, HIPAA policy. That one is pretty critical because you want to have the HIPAA policies and procedures in place, and then have a record. This is going down to the third to the training records. I can't count that fast, but having a sign off at that every employee, even if they're not a provider, I mean, especially support staff, that's where unfortunately we see a lot of exposure, and it's because those folks aren't trained. It's just assumed, oh, she's just in billing. No, that's medical records for sure. And so you want to have documentation that the staff have received the policies and procedures and they've been trained on them. And the HIPAA training, you can get it online. It's very straightforward, easy, and it's going to help you 100% better position. And then the notice of privacy acknowledgement signed by the patient. When you get an audit or an investigation where they're looking at medical records and you don't have that, that can be problematic. So you want to make sure you have that, just make it part of the record. It should be just part of your intake sheets. And so I think the other ones are kind of Kathleen already covered on the encryption. So the next slide, and this is an example, sample employee confidentiality agreement. So again, this is what I was just talking about, having your staff, everyone from the top to the bottom, understand this, have a record of it, and then maintain that. And again, if you are audited by the Office of Civil Rights, which is who enforces HIPAA, which is what's more likely is that you get a patient complaint. Because patients are very savvy. If they complain to OCR, that's more often where I see it with my clients is a patient says, well, I had one where a patient didn't agree to email and then got emailed about her own records and she complained to OCR. And so again, it didn't result in like a huge fine, but it was a real headache to sort of deal with. So again, in terms of mitigating your risk, these are just kind of some things we've talked about in terms of like not sharing passwords and encrypting laptops. Again, I think that employee training is probably one of the most important ones because it's typically, in my experience, it's a staff member who didn't know, right? Wasn't aware of the risk of having this information, answered the phone and gave out information, not understanding who they were talking to. One real simple thing is training the staff when a patient calls, ask 2 questions to verify. Address, phone number, real easy, right? They're looking at their screen, they're checking and making sure, and then they're documenting that when they take the phone call. That will save so much, especially if it's someone who's like, again, the scam, all the different phishing scams, all the stuff that Kathleen talked about. And again, that last one in red is using the encrypted text or email. I would just have those platforms already in place. And then you would have your patient sign this consent. That way, then you're all clear on that. If you don't have the consent, it does increase your risk. I would say most patients by this point, they want the freedom and the convenience of online communication. So usually that's not an issue, but it's so great to just have exactly what the patient is willing, what kind of platform, what kind of communication they're consenting to, and to have that in the file. That is really critical because it just takes the one patient who, well, I don't want to be emailed about this. And again, every specialty is different. There's all different types of patients. Some I think have more risk on some of these than others. But just across the board, this is usually a great idea. Okay, next one. Medical board complaints and investigations. So I think this is another one of the top 5 risks for your practice. And so I think, let's see. All right, file the complaint. Yes. So this is, one second on Google gets you to this page. So it's very easy for patients to submit a complaint. You can see with the red arrow there, you click that, boom, 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 you type it out, you submit it. And so this is just kind of emphasizing like how easy it is for patients to make complaints. Patients are very savvy. A lot of what I see in some of these really like what I'll say benign complaints is a dispute over some kind of payment thing, especially where patients don't understand. Insurance is complex. how healthcare is paid for is complex. And so that's where we see a lot of it. And so what starts from the complaint, typically, well, not typically, what happens is the complaint first goes to an analyst, and the analyst will reach out to you, the physician, usually by a letter, for the address you have on file with the board. So you want to make sure that's accurate. And they say, hey, this patient complained about this, that, and the other. What's your response? That's the best time to go to your malpractice carrier, a lawyer, someone, intervene, someone to help you, someone in the legal field to help you respond to that complaint. Because most often that's where we can just respond, explain what happened, mitigate the risk tremendously. And most of those, I will tell you, close. Most of those we can have that shut down. It's completely private. The patient just gets the letter saying it's been closed. You get a nice closure letter. You don't have to disclose it on any kind of credentialing. It's not an open investigation. So that is pretty critical because the other, once it goes beyond there, it goes into the investigative stage. And then it can go beyond up to like the Attorney General's office, and that's who would bring disciplinary charges. Oh, thanks. So this is kind of shows you the statistics on the complaints with the board for the past 5 years. You can see it's pretty much fluctuated downward to 2022. So kind of, and seems like it might be pandemic related, but now we're sort of ticking up a little bit. And most of these, I would say, so out of the statistics, so one of the top ones is the Cures database. There's been audits going on with that. And so there's investigations that come out of that. Again, it's going to start out as an inquiry letter to you. And so you need to be quick to respond and make sure you're involving legal counsel. Your malpractice carrier is looped in on how that response is. The second is not giving patients records. And the third is patient abandonment. And this typically happens when you're leaving a practice and you're not giving patients notice that you're leaving. The license and restrictions and suspensions, again, these are more stats that the medical board put out just a month ago. Interim suspension order, those top ones about the restraining orders, those are usually they're newsworthy. So they're very, very, very unlikely. And then you can see there kind of the cases, like what the ones that are kind of the most high are mental, physical illness, and self-abuse, drug and alcohol. So those are what we see quite frequently. And so that's what can, result in a restriction or suspension, which again is like the most extreme type of discipline that they bring or brings. Okay, administrative and probation violation outcomes. And so you can see on the top, revocation is the most extreme. That goes on down to, public reprimand. So public reprimand is kind of, we call it slap on the wrist. It's still discipline. It usually is going to, most often is reportable in credentialing or other licensing boards, which kind of brings me to another thing. If you're licensed in another state, discipline in that state, California almost always gets notice of it, especially if you're the National Practitioner Data Bank. They almost always do their own investigation and want to do their own type of, is it public reprimand or what have you, even if it didn't happen in even if the underlying, wrongful conduct, if you will, didn't happen in California. California is pretty strict on this. And so you really have to loop in an attorney to help you sort of navigate that, to make sure that you're kind of covered all there. But the actual discipline out of a complaint, which we talked about a couple slides ago, is usually very unlikely. Most of the time, complaints are, again, like Kathleen pointed out, patients who are upset, patients who are like just not happy with what has happened with them medically, and they complain to the medical board, and the medical board by law has to look into that. They don't need to do a full investigation and involve the Attorney General. No, that's if there actually is something there that's a violation of the Medical Practice Act. But just an upset patient it's something that they just can look at very quickly, and they'll loop in the doctor, get the doctor's side, realize there's nothing there, and close it. So that's mostly what we're dealing with in terms of mitigation of risk. But it's good to know these are kind of the different levels of discipline. So the medical board, the criminal actions. So this is criminal convictions. They're reported upon conviction. There's, I believe it's a 30-day reporting requirement. But the Department of Justice, like it says there, they can notify the board of an arrest. I was just counseling on a client on this today, that it's unfortunate if they do that, because a lot of times your criminal defense attorney doesn't want you saying anything while that's pending. So it's a little bit challenging to navigate both at the same time. But in my experience, like I would say most of the time, you're reporting the conviction, and then from there on, the board will do its own investigation. And then there's also the business and profession codes. There's mandatory reporting that way as well. Let's see the next one. So this will kind of go over the 3 most common causes for disciplinary action. So we've got gross negligence, an extreme departure from the accepted standards, repeated acts of negligence, and incompetence. And so this is, again, across like all different disciplines, usually coming out of a medical malpractice settlement that has to be reported. That's usually where that comes out of. So you can face licensing board discipline on top of that. Gross negligence, these are kind of lists of what that looks like. You know, where kind of going back to what Kathleen said about like the documentation being critical. You know, I've had clients before end up with extreme departure when really, at least from my point of view, it was really documentation was really, really poor. But again, it's hard to, like Kathleen had mentioned, it's not very defensible if it's not there. And unfortunately for this particular physician I'm thinking about, it wasn't there in like many patient records across the board. So that was very challenging. So you just want to, you know, keep that in mind. So that's gross negligence. And the next one is repeated negligent acts. So it could be one thing that's a simple negligence, which is usually something, you know, like not recording like the vitals or something like that. But it's repeated across the board, right? It's happens more than once. And so that will trigger a repeated negligent acts, which will probably end up with more discipline as opposed to just one minor documentation error. And again, this a lot of where I see this is it comes out of a medical malpractice case. I need to kind of quickly go through. So incompetence, again, I guess I would just say like refer out to a specialist on this. Don't try and be all to the patient. So I think that's the third one. And then the next slide. These are other causes of discipline that we see. We kind of already talked about the crime, substance abuse, you know, a lot of this ends up being reported one way or another. Patient complaint, mandatory reporting, there's kind of multiple ways to do that. Or someone else gets investigated. So that's how these things come into being. Audits. You know, if an audit gets pretty egregious, audit by a payer, they can make referrals to licensing boards. So that's how a lot of this kind of gets before the board. So next slide. I think we're getting to the end. This is a new statute, relatively new. I think it's been around 3 or 4 years. So this is a new sexual misconduct reporting statute. So this is for either an institution or a healthcare facility, so hospital, an academic institution, a licensed clinic. That's who has the obligation here to report. But you'll see there, it's a very short report. What they're reporting is if a patient makes a written complaint of sexual misconduct about a provider, about a physician, physician. It applies to other providers too. That's why I said that. But a physician, it has to be reported to the board. So this basically gives the institution, the hospital, the clinic, the ASC, whoever, literally no time to investigate. That's not enough time to look and determine if it's accurate. So it just gets reported. So I have handled many 805.8 investigations. That's what they call them. So if we go to I think that's the last slide for me, kind of describes, you know, so what happens, what I will say is a lot of these are just complaints that probably would not have ended up in front of the board, but for this reporting statute. But it is very labor intensive to sort of defend one of these investigations. But with the mandatory reporting statute, that's kind of the world we're living in. And if you don't, so if any of you on the call are on a leadership position with one of these institutions, not reporting it. So saying, well, that isn't really, I'm not really sure. It's a $50,000 fine for not reporting. So that's why there's a lot of 805.8 reports, because there's no time to investigate and the stakes are too high to just sort of say, well, I don't really think the board would care about it. So it's been a kind of a huge change. That's why we've seen a big uptick in sexual misconduct investigations. But for the most part, at least in my experience, they have really not amounted to a whole lot except for headaches for the physician having to deal with the investigation. So I think that was my last slide.
Thank you, Kathy. We're going to, I'm sure, have some questions about this. I wanted to say something about the doctor's company and other malpractice carriers, because you've heard all this about the medical board. Well, at the doctor's company, your MediGuard coverage covers you when we provide an attorney for the medical board, and I know other carriers do as well. So you really want to hear what Kathy said. Notify your malpractice carrier, and don't ever for a minute think that the medical board is your ally. They are the ally and advocate for the consumer. And there's a lot of things going on that have changed this year. So I really thank you for bringing us through what the issues were. I want to just make a couple comments about social media. You may not even be involved with social media, but you are in a customer service business and you want the referrals. People go on to the internet to see what's going on. I had a complaint this week from someone, and I went on and I looked the doctor up and I said, I've never seen a doctor with so many 5-star social media comments. It was amazing. And there was one, I would give 0 stars if I could, because, and as I said to the physician who was really upset, people understand that people retaliate and go into social media. The most important thing for you to hear tonight is that it is a HIPAA violation to respond to a comment. You cannot acknowledge the person was your patient, even if it's a positive thing. You can't say, oh, it was so great to have you in our office. Everybody loved you. You're great to take care of. You have to have something that's non-specific. Like, we always appreciate, favorable comments posted by anyone who's been to our office or something. You are bound by HIPAA. The customer is not. So they can put anything they want in. There's no such thing as social media privacy. And don't forget, metadata posting is also on the footprint of every social media site. Basically, rule 1, don't post anything online you don't want to see on the front page of the newspaper. Rule 2, do not respond. Please don't engage in any arguments online. And also, if you feel compelled to respond, we had our legal counsel several years ago prepare for the people who said, I have to have something. I can't let this go by. So here's what we give our insureds. But here's what I say when I give that to them. I said, I'll send it to you, but I can assure you, the person who wrote something that was not nice, if you post this, it will be poking the bear, and then they will post something that's worse than they did the first time. Mm-hmm. And I've lost count of how many times people call me back and said, I wish I would have listened to you. It was worse the second time. So patients have no HIPAA responsibility. The business code in physicians makes us have CME that includes cultural competence. I'm not going to go into that. You can review those slides at your leisure when you get them. We are at the end of the session. I want to share our closing slide from Sir Winston Churchill. This is about you. We make a living by what we get, but we make a life by what we give. You give every single day. You show up and you give to the people regardless of how challenging they may be. We have articles and resources. And with that, I am going to put my slides down, Jen, and let's go to see if we have any questions.
Thank you, Kathleen. We do have quite a few questions online. Let's see. The first question, what is the timely manner to respond to PHI requests?
Yeah, I believe it's 15 days under the health and safety code. So you want to do it rather quickly.
I want to say that I get calls from doctors who are upset because they say they can't do it in 15 days. And what we tell them is then let the people know I have to get the records out of storage or I have no staff. It was crazy during COVID because doctors' offices had no staff even.
Yeah. So just make a contact.
Tell the people.
Yeah, have a contact point within, I would say within 2 weeks, have a contact point. We're working on it, and just document that, document the phone call, the email, what have you. Yeah.
What about if a patient has dementia or memory issues? You told them to follow up on a lab and they didn't. Is it your responsibility as a physician to notify a family member? How is that handled?
I'll answer that one. From a clinical standpoint, first of all, if you have someone that you think has some cognitive deficit, you should already know that and think about, who is the person. Sometimes you can go to the emergency contact and you could call. And if Jen was the emergency contact and I was the office manager or the MA, I could call and say, Jen, Mary Smith has you listed as her emergency contact, and we've been trying to reach her and cannot. Could you please get a message to her that we need her to contact us as soon as possible at this phone number? Now, Jen says, because I already looked and there was no HIPAA authorization signed. So Jen says, well, what's it about? So I can tell her. And the only answer your staff can give is, I'm sorry, we follow all federal and state privacy laws and we can't provide any information. We just need her to reach out to us. But if you have a patient that has some cognitive deficit, it's time for you to know that only a psychiatrist or a neurologist can do an evaluation that the courts will accept for conservatorship or for, for illegal papers to go to court. So a family practice, they will not accept that. So if you have someone that's sliding, think about getting them a referral, giving them a referral to a neurologist or a psychiatrist so that you can be prepared. But a lot of times you get people you have no clue. And that also goes with documenting non-compliance. The doctor's company recommendation is 2 phone calls and then a letter. And so your office staff calls twice and then you send a letter that says, we've called you on date and date regarding getting your labs done. We've had no response. Please contact us. It's important. And if you're with the doctor's company, you can call us and we help you with those letters.
One question that came in, what is the biggest risk for physicians that work with trainees and or students?
Do you want to say something on that from a legal standpoint, and then I'll comment on a clinical?
Sure. Yeah, I think it's the supervision and documenting that. So if they're working under you, and again, it kind of depends on the billing and whatnot, but if you're supervising them, you want to make sure that you're actively doing that and that you're documenting it would be my recommendation. But yeah, the risk is that you're responsible for them.
And she's right on target with the whole thing about supervision. An issue that we see is people say, well, I have someone from a school or someone in my family that wants to come in and observe, and they have to meet all the same requirements as an employee. So they have to have a TB test. They have to be screened. If you do background checks on your staff, you'd have to have a background check. If they're from a school and they're coming in to observe, I know I'm involved with Chapman University Health School, and I help partner them with their PA program to get PA interns, and they have paid internships and they have just observation interns, and the school has to provide a letter and they are under the liability of the school, or you have to know who's liable, because your malpractice policy is not going to cover volunteers and people that come in and observe. And if you want that to be covered, you need to talk to whomever is your broker or your malpractice carrier and ask, how do I need vicarious liability? Do I need a policy? Do they have to have their own policy? If they're not licensed, they can't do anything. They can't do a procedure and help you. That's unlicensed personnel. We see a lot of that with the medical board where people have an intern in and they let them participate in a procedure in dermatology, or, well, you can hold this, or here, you take the clip and you see if you can pull it. No, they're not licensed. They don't get to participate, but it'll be on your license if there's a complaint.
If a patient wants their notes at the end of a particular visit, is it advisable to hand them over, or should you ask them to sign a release first before handing them over the copies of the record?
Well, they don't need, if you give them a copy, first of all, most EHRs generate a summary visit note, and that you can give them. You don't need anyone to sign an authorization to get a note out of their records at the date of the visit and they're in the office. The visit note, most doctors may not even document till that night or the next day, so they don't have the note ready. So they can say, I don't have the note ready. If they have an EHR with a portal, you can tell them the note will be available within 24 to 48 hours. You can go online and see it, or you can print it yourself. But patients, I get that a lot when patients call on the phone and say, I want to get my records. If they're in the office and ask, they can get it. But as you heard from Kathy, there's no such thing as verbal consent in HIPAA. There's the only way to get the record is if you give a written request or you sign a release. And now, if you have a portal on your EHR and your patient goes in and puts a note in the portal, that will suffice as a written request, but only from the patient. The patient's husband, spouse, friends with benefits, they're not entitled unless the patient has signed an authorization to release to them.
And then talking about medical records, how do you get text messages into the medical record?
You want to take that, Kathy?
Yeah, I mean, either if you have the text messages on one of those, HIPAA compliant platforms, then hopefully you could just track that into your EHR. Otherwise, if you're talking about, hey, we have text messages and for, I don't know, maybe a certain patient, yeah, I mean, you'd want to kind of work with maybe your IT. It's kind of more of a technical question, but you want to get those in the record, I think, is what the question is, yeah, you want to get those in the record and then have some kind of platform where it's like, it's connected so that the text messaging is done on a separate app that then is speaking with your EHR platform.
And she's right, there are platforms. I do want to tell you, I've done a number of productivity studies with accounts who do a lot of texting. It's not encrypted. I said you can't do that. It all has to be in the medical record. So I can tell you by experience, the average time to download or to take a photo shot with your camera of a text and then to print it and scan it into the medical record on average takes about 6 to 8 minutes. So I had one practice that had, they said, we have like 150 texts a week we have to do. And what they found out after they did the productivity study, I said, just do it on a sense of this many. And they called me and said, we're not doing any texting anymore because it's going to take 12 weeks out of the year of time. That's how much time of our staff. And it was a solo practice. And they don't have that time. So I told the doctor, knock it off, don't text. And it's better because it's very informal and those things show up. And Kathy can tell you they'll be on a big electronic screen in the courtroom, right, Kathy?
Yeah.
That note. And so and there's also a lot of typos in text, so it doesn't look really professional. So unless you have a platform that has encryption, don't text. And hopefully you have one that you can, have it sent directed to your EHR.
Mm-hmm.
Kathleen, do you think we have time for one or two more questions?
Yes, we have a couple of minutes and then we're going to close the meeting. Now, let me say this. If anybody needs to leave now, we want to thank you for joining us tonight. I want to thank Kathy for her excellent presentation and Jen for the excellent hosting and to Paul for being our partner. Paul's not there, but we think that San Diego County Medical Society really supports physician education, and we have other programs each quarter. We have one coming, so thank you for that. But Kathy and I are available, and we are committed to staying for as long as you'd like to, Jen.
Terrific.
A few minutes.
Had a quick question related to dentists. Are there HIPAA obligations when volunteering for veterans providing dental care for them?
For veterans?
Yeah, I'm not aware that there's any exception. So, HIPAA applies just to all medical records,
including
so
volunteering.
Even if you're, so even because I've done work for specialty clinics, nonprofits, and it's just the same rules. So.
One thing that didn't come up that I want to just remind everybody is a business associates agreement is required. And that's under HIPAA, federal and state HIPAA, and a business associates agreement If you have a webmaster, you have to have it with your CPA, with your accountant, if somebody's outside your office, with your billing company. You have to have it. The doctor's company recommends the Health and Human Services Business Associates Agreement. If you need that, you can go online and get it, or my email and number is at the end of the slides. If you notify me, I can send it to you.
All right.
Yeah,
well, I think if we, I'm sorry, Kathy, did you have one thing else?
Yeah, I was just gonna say, yeah, with the BAA, that is important, especially with the billing company. They notoriously don't have those, and it's very problematic when you want to get your records from them. So, yes, just want to mention that.
All right. Well, if we did not get to your question this evening, we apologize. We went over just a little bit. I want to thank Kathy and Kathleen for a terrific presentation. Thank you to all of our attendees who took time out of their day to join us this evening. Lastly, if you are a physician, not yet a member of the Medical Society, please consider visiting our website located at sdcms.org. You can find out more information about becoming a member, the various benefits that we do offer, and you can easily join online in less than 5 minutes. So thank you, everybody, and I hope you all have a great evening.
Thank you.
Thank you.
Bye-bye.